Welcome to the DCHA podcast. I'm Jennifer Hurt, AVP of Communications and Member Engagement with the association. On our podcast today, Keeping Care Running During Long Cyber Outages, we're talking about business continuity for hospitals during cyber incidents. These incidences can cause extended downtime for weeks and even months and cost millions of dollars. Just think back of the Change Healthcare outage that disrupted claims nationwide. My guests today are Gerry Blass from ComplyAssistant and Rizvi from DCHA. And before I get started, I do want to congratulate Gerry on celebrating his 25th year anniversary with ComplyAssistant. So congratulations, Gerry.
Thank you, Jen. Very happy to be here. It's hard to believe that we go back to even a little bit before the HIPAA days when we started ComplyAssistant and lived through all the stuff that's happened since then. So it's a real pleasure to be here today and to take part in this with you and Eddie.
Great. Thank you. Hi, Eddie.
Hey, thanks for having me. This is Eddie Rizvi from DC Hospital Association. I'm the Senior Director of Emergency Management. Been here for about 1 year, and I got started in this field of emergency management during COVID, where I worked in New York and New Jersey. And now I'm here in DC, and while we do an all hazards approach for emergency management, there's a lot of emphasis right now on cybersecurity and extended downtime. So happy to be here.
Great. Thank you, Eddie. So let's go back and forth with some questions and answers. The first one is for Gerry. What extended downtime incidents have we seen in the last 2 or 3 years?
So Jen, yeah, you mentioned Change Healthcare 2024. That, as you mentioned, claims and eligibility disruptions nationwide. HHS and news outlets reported widespread cash flow impacts. 2 providers of all sizes. Later disclosures indicated well over 100 million individuals affected. United Healthcare estimated multi-billion-dollar impacts. Then we had in same year, in May-June timeframe of 2024, Ascension, HR and clinical systems offline. Downtime procedures for weeks. Restoration began in early June. 2022, Common Spirit, multi-state. EHR downtime. The system later reported 160 million in costs tied to the event, and other examples include Prospect Medical in 2023, which was ED diversions and service disclosures due to a cyber attack. So there's nothing like these kind of examples to bring attention to the impact, short-term and long-term, and it brings awareness. Certainly, Change Healthcare is the biggest. There's been big health systems that have been down for months and had to divert all kinds of services and shut down departments. And the impact is really not just about PHI, protected health information, but protecting patient safety and lives.
Thanks, Gerry. So going back to that, Eddie, what's the worst case scenario for hospitals?
Yeah, well, so when a downtime or cybersecurity issue happens in a hospital, the patient care always continues, but the risk curve kind of goes up. And for the first day or two, teams can muscle through the paper, but by week 2, you're dealing with sustained friction everywhere. Patient registration, orders, results reporting, medication administration, imaging workflows, everything becomes slower and more error prone because you're relying on manual handoffs and human memory. You also start seeing throughput impacts, longer ED wait times, delayed discharges, and potentially diversions if safety thresholds are crossed. Clinically, the hardest part are the things we usually take for granted, like medication safety checks, allergy alerts, clarity, tracking labs and critical values, blood bank coordination, and making sure everyone's working off the same information. Operationally, you're running a marathon. Staffing is fatigued, documentation's backlogged, and the constant need to reconcile paper notes back into the record later.
Thank you, Eddie. So obviously we know that prevention is less expensive than ransom. So Gerry, what are some controls to reduce the chance of a successful attack?
Okay, Jen, that's a great question. So from HHS, what they call CPGs, Cybersecurity Performance Goals, and the 405D, which is the HICP, Health Industry Cybersecurity Practices. There are 5 top controls that can reduce risk. So multi-factor authentication. I'm sure a lot of folks have heard about that now. We see it in everyday transactions that we do with banking, and when we're logging in, we get a code to verify the login. That's a multi-factor authentication, and it reduces the risk of someone stealing a password and gaining access to an app that is critical. Endpoint detection and response. So those are systems that are now being enhanced by AI to detect someone or an anomaly on a network. Someone's on there that shouldn't be on there. It can detect it very quickly these days, as opposed to what it used to be. A long time. Could have been 250 days before detection. So endpoint detection, network segmentation. When you think about Change Healthcare, the one problem caused nationwide downtime. If you segment networks and build zero trust around in healthcare EHRs and critical services, you can reduce the impact of a nationwide type of outage on a big network controlled by a vendor or a big health system. So network segmentation is big. A lot of this stuff is all based for IT to focus on. Immutable offline backups with periodic restore testing. So knowing that the backups that you have can be restored, that's very important. A vulnerability patch management with tight email and remote access controls. So the patch management, obviously, it has to be done periodically, really continuously, so that the latest security patches are in place, and that can help to reduce the risk and prevent a successful attack. So these are the five. Again, you can refer to HICP, and you can refer to the CPGs out of HHS for that kind of detailed information.
Great, thank you. So now that we've talked a little bit about reducing the chance of an attack, Eddie, how should a hospital prepare for extended downtimes?
Yeah, I always say you should plan for the people and the paper first because that's what you'll actually be using on hour one of a downtime. So downtime kits shouldn't be theoretical. They should be real. They should be stopped, unit specific, forms, labels, medical records, medication documentation tools, downtime order sheets, quick reference cards, and like a simple what changes when systems are down one pager should be available at all times. And then you should build your human workflow. So examples are buddy charting, runners, designated documentation leads on units, and a process of how orders get written, verified, executed, and logged, especially for high-risk areas like pharmacy, lab, blood bank, radiology, and operative services. Don't just do a 4-hour drill. Extended downtime is different. It's about shift changes, weekend coverage, supply replenishment, and keeping accuracy high when everyone's tired.
Thank you. So, Gerry, let's talk about the playbook. Tell me a little bit about this playbook and how often we should tabletop test.
Okay, so some good references for a playbook. Basically, what a playbook does is it provides a strategy to deal with a downtime, especially an extended one. And it can reduce the panic, the anxiety, the stress that is going to be there during a downtime like this. But by having a playbook, it could be more organized as a response. And so a guideline would be the Health Sector Cybersecurity Council, which is HSCC. They have an operational continuity cyber incident resources called OCCI that gives step-by-step guidance during extended outages. And of course, going back to, like I said, 25 years ago, right around there, the HIPAA security rule does have a contingency plan element section, which provides elements around backup, disaster recovery, emergency mode operations, testing and revision, and criticality analysis. A staged restoration runbook provides for clean room rebuild steps, validation gates, and rollback. And then clinical downtime workflows per service line are important, mandatory, plus revenue cycle steps for electronic claims contingencies. And that, again, going back to Change Healthcare, was the biggest problem that occurred due to that downtime was the outage that prevented the processing of electronic claims. As far as the frequency goes, Jen, at least quarterly, the tabletops that include at least one multi-week scenario each year for extended playbook.
Great, thank you. So, we all know communication is very important, especially keeping people informed when there is a downtime. So, Eddie, how do we do that? How can we keep everyone informed from top to bottom during a downtime?
Yeah, this is where organizations either stay aligned or they kind of drift into the chaos. The key here is deciding the cadence of meetings and huddles up front and sticking to it. So, for an example, some frequent things that are done in a hospital are operations huddles for people that are running the incident. It's a predictable executive touch point, and there should be like fixed staff updates at set times so units aren't constantly guessing what's changed. You also want to reduce some of the miscommunication. So pick your primary channels of communication, whether that's mass notification, SMS, email, intranet, And that's all if that's available during a downtime. If that's not available, you got to resort to printed unit updates if the digital tools are down. And then you got to make sure every message answers the same basic questions like, what's up, what's down, what's the workaround, and what's the expectation for the next shift, and who to call if you have questions, and who can help.
Thank you, Eddie. Okay, Gerry, this question is for you. What are the benefits of a co-location hot site? And for the non-tech people, what is a hot site?
So a co-location is the key because we're not talking about a single location that if it's down, you're dealing with extended downtime. So what many health systems are doing is a co-location, especially EMR, which could be hot, meaning immediate, or warm, meaning standby, which lets healthcare organizations fail over fast, meaning it's almost like turning on a light switch in a room when it's dark. All of a sudden you have light again. And so by failing over fast, if the primary site is unsafe, then you fail back once it's clean. The benefits are shorter clinical downtime, elastic capacity during surges, regional diversity, cleaner recovery testing. It fits the NIST, National Institute for Standards and Technology Recovery Guidance. It will help with the playbooks, milestones, and test both the fail over and the fail back. The key is rigor, keep data sync tight, isolate the hot site during an incident, and practice the cutover. So really what it all boils down to, if you want to talk about it in simpler terms, is that without having this kind of a co-location environment, downtime doesn't have the ability to just do a switch. And so you're stuck with whatever the downtime is going to be. If it's going to be 3 days, a week, 2 weeks, a month, 3 months, you're dealing with that. And that's, again, you have to plan for, but if you have a co-location, immediately switch to that location. Could be from going from on-premise to the cloud. Continue with the EMR in operation and other critical apps. And then when the problem is resolved, bring it back. And it's as if you didn't have a downtime, from a standpoint of a simple way to look at it. And that prevents all of that extended downtime impact that we've seen occur with the examples we talked about before.
I'm actually scared to move on to the next question, and I'm scared of the answer. But Eddie, what does extended downtime cost from a tangible and intangible perspective?
Yeah, I mean, tangibly, I can give you some examples. I think is Scripps Healthcare in 2021, 112 million over 4 weeks of revenue loss. Common Spirit in 2022, 160 million loss, and Change Healthcare, which everyone is talking about nowadays because it was a very recent big cyber incident in 2024. They're talking about estimated costs of 2.3 to 3.1 billion, and that's billions with a B. So that's the tangible costs. And, there's obvious costs like lost revenue, delayed billing, direct spend on incident response, forensics, overtime, temporary workflows. All these things cost money, but there's also intangible costs. And this is the stuff that people underestimate. And when systems go down for an extended period, staff get really burnt out. Documentation gets harder, handoffs get riskier, the chance of delays or mistakes increase, not because people aren't trying, but because the system isn't supporting them. You also see service disruption, active procedures delayed, diversion decisions, reduced throughput, and knockout on impacts across the region.
Yeah, it's scary to think of it in those terms. So Gerry, then let's move on to cyber insurance. What should cyber insurance include for an extended downtime claim? Terrible event that someone needs to process a claim.
Yeah, so the insurance should cover the business interruption, obviously, contingent business interruption, third-party outages like a clearinghouse, like Change Healthcare, data restoration, incident response panel, which would include forensics, legal, public relations, breach notifications, and more, extortion, ransom, regulatory coverage were allowed, and clear war active state language, pre-agreed hourly rates, and rapid access SLAs for vendor teams. Align these with the OCCI style that I mentioned before from HSCC, the Health Sector Council. Now, with all this coverage, though, comes the requirement to meet the attestation of controls that are in place so that the insurance company can actually underwrite the cost of a premium for the policy based on controls that are in place. And at times, some healthcare organizations would get the insurance, make attestations, have an event, have an incident, and if the insurance company finds out that those controls are really not all in place, then you can't expect coverage. So it's very key to be in sync with the insurance policy requirements and the fact that when the requirements are met, that the insurance policy does cover the items that we just mentioned.
Thank you, Gerry. All right, last question, Eddie. Are you ready? So let's say we have a downtime event, we have a cyber incident. How can we lower our odds next time?
Yeah, absolutely. So what I've seen in incidents is that, the incident happens, there's a response to it, and then it's over and everyone's relieved that it's over. But I think step one here is to have the discipline and the speed to do a hot wash within 72 hours while the details are fresh, and then turn it into, a 30, 60, 90-day improvement plan with clear owners and clear due dates. The goal isn't a perfect report. It's rapid, measurable risk reduction. From an emergency management lens, the big question is, what was done in the first 15 minutes, the first 6 hours, the first 72 hours, and, did we have it taken care of? And that means tightening the incident management piece first, clarity on who has the authority to declare a downtime and escalations, stand up, a predictable command rhythm, and make sure your internal communications are consistent across shifts so staff aren't improvising. Then, busting out the plan and making the edits as needed.
Thank you, Eddie. Thank you, Gerry. It's clear that there's an important connection between technology and emergency management and the importance of them working together in these types of situations. So thank you both again for joining the podcast today. I also want to give a special shout out to Gerry Blass with ComplyAssistant. ComplyAssistant is an associate member of DCHA. Our associate members are very valuable as they help support our projects and initiatives. So thank you, Gerry, for your support and for being an associate member of DCHA.